When talking about respiratory drugs, we need to differentiate between drugs that are inhaled and drugs that are systemic. Inhaled drugs are going to act locally in the bronchi and lung and are going to have fewer side effects in general when compared to systemic drugs. The main disadvantage to inhaled drugs is that it highly depends on the patient's technique in doing the inhalation, and then it also depends on the severity of the disease. There are some patients whose disease is so severe that they can't actually get the drug down into the bronchi deep enough to be of much use. The advantage of systemic drugs is that it doesn't matter how bad the disease is, you know you're going to get a high dose of the medication to the patient via the bloodstream. The downside, of course, is that there are potentially more side effects. There are three basic different types of inhaled drug delivery mechanisms. The first is called the metered dose inhaler, and it's this green one up at the top right. They take quite a bit of hand-eye coordination and breath coordination in order to use properly, and most people actually don't use them properly. To aid in the absorption, you can add what is called a spacer. So everyone needs to know how to administer an MDI correctly. So exhale deeply, breathe in for as smoothly as you can for a count of 10 if possible. So breathe in. Now hold it for a count of 10. And breathe out slowly. If 2 doses are needed, you need to wait at least a minute in between doses, especially if the drug you're delivering is a bronchodilator, because you want to give it a little bit of a chance to work before you use the next one. If you're using 2 different inhalers, say perhaps a bronchodilator and then an anti-inflammatory, you always want to use the bronchodilator first and wait at least a minute or more before you take the anti-inflammatory. That way it will give the bronchodilator a chance to open up some of those smaller passages while you're waiting for some, which will allow the anti-inflammatory drug to penetrate deeper. When you're using a metered dose inhaler, you don't have to press the button and breathe in at the same time. You can press the button and then breathe in. Dry powdered inhalers come in 2 major forms. The first is a capsule form. So you put the capsule inside this little chamber, press the little buttons, and then the buttons pierce the capsule, and then take a breath. The other form is the discus, which is only used by GlaxoSmithKline medications, and this little dark purple shield folds back to reveal the mouthpiece. There's a little lever that you press, and once you press it, it will cock the inhaler, and then you'll notice that there is a little counter right there, and that counter will advance by 1. Put it up to your mouth and take a breath. Supposedly, DPIs are actually better at delivering medication than metered dose inhalers are. The final inhaled drug mechanism is called a nebulizer. This is the old-fashioned kind, the kind you're most likely to see in the hospital. This little cup unscrews and you pour the medication inside this little chamber. Then you connect the tubing up to air and ask the patient to put it in their mouth and breathe. This little tube right here is an extension that can be placed on the end of the inhaler, which basically just traps some of the excess nebulizer that comes out the back. There are 2 major categories, not classes, but categories of medications when it comes to drugs for respiratory in general. Those are bronchodilators and anti-inflammatories. Under bronchodilators, we have adrenergic agonists. These are drugs that activate beta-2. And then we have anticholinergics. These are drugs that inhibit acetylcholine receptors, muscarinic receptors, in the bronchi. And then finally, we have a class called Methylxanthines, which are stimulants similar to caffeine. Under the anti-inflammatory drugs, we have three of them. We have steroids, which we've already learned about in the past, so you can give both inhaled steroids and systemic steroids. Then we have what are known as leukotriene inhibitors, which are an inflammatory mediator, and so when you inhibit it, it sometimes helps breathing. And then the last one is a drug called cromolyn, which is a horrible, crappy drug. The only reason I put it on here is because for some reason people like to put it on standardized tests. I don't know why. It's a horrible, old, crappy, disgusting drug. We will talk about it later. When it comes to adrenergic agonists, we need to differentiate between the non-selective adrenergic agonists and the selective adrenergic agonists. So at the top you can see ephedrine, epinephrine, and isoproterenol, and all three of those are non-selective. Epinephrine is the least selective of all the adrenergic agonists, and really its major use in asthma is for status asthmaticus. That's when the asthma symptoms have not disappeared after treatment for at least 15 to 20 minutes. Epinephrine is also available over the counter. The brand name is Primatene. There are other brand names though. And it has more side effects than albuterol. It's more dangerous than albuterol, more likely to cause sudden death than albuterol. And yet for some reason it's over the counter and albuterol is not. Go figure. Then we have newer selective beta-2 agonists, and the main one is albuterol. We'll talk about some of the other ones a little bit later. Those have fewer systemic side effects. They promote bronchodilation, they suppress lung histamine, and they also cause increased ciliary motility, which is going to help a patient cough up any mucus that they have. The adverse effects of all adrenergic agonists in general are tachycardia, nervousness, irritability, tremor, angina or chest pain. That's primarily from beta-1 stimulation, not beta-2 stimulation. Inhaled preparations are less commonly associated with these side effects. Oral preparations much more commonly associated with the tachydysrhythmias, in particular, fast heart rate. The adverse effects are usually dose-related, and they can also be related to additives to the inhaler. I had several patients who told me that name brand albuterol didn't cause any problems, but the generic albuterol did. Beta-2 agonists are divided into two groups, short-acting and long-acting. Long-acting begin immediately, and they last somewhere between 3 to 5 hours, depending on the drug. Long-acting can begin anywhere from 2 minutes to 30 minutes, and they last typically 10 to 12 hours. The key thing to remember is that short-acting are the only ones that are allowed to be used as rescue inhalers. Long-acting are never allowed to be used as rescue inhalers, because if a patient takes the long-acting by accident, thinking it's a short-acting, they could potentially die while they're waiting for it to work. You typically give these drugs either inhaled or oral. If the patient has status asthmaticus, you give it to them by injection, epinephrine by injection. Generally speaking, the short-acting are used PRN for symptoms, rescue inhaler, and then long-acting are done on a fixed schedule. Whether you feel like you need it or not, you take it when it's time. So here we have a listing of some possible drugs. Under short-acting, albuterol is the #1 most common drug, and it's one you need to know. Levoalbuterol is the left hand of albuterol. Albuterol is a racemic mixture, so it has left and right hand drugs mixed together. And then levoalbuterol is the left hand only. Supposedly it works a little bit better and has fewer side effects. Up until recently it was nebulizer only. I think it is now available in an inhaler form. I just checked real quickly and it is available as an MDI now. Next we have the long-acting agents, salmeterol and formoterol. Now, salmeterol used to be available as an inhaler. However, patients were taking it by accident thinking it was their albuterol, and then it was associated with an increase of sudden death. It's not that the drug itself kills you, it's that you use it inappropriately. So now salmeterol is only available in combination with other drugs, such as an anti-inflammatory, which you don't take as a rescue inhaler. Formoterol is available as a DPI, so it's typically not going to be mistaken for an albuterol inhaler or other rescue inhaler. There are some other long-acting agents now on the market, but for now you don't need to know them. Lastly, we have the oral ones. We have albuterol, which can come as tablets, extended tablets, or syrup. Those are typically for patients who can't inhale well, often children. And then we have terbutaline, which is available as tablets as well. Terbutaline is not really used that often for asthma anymore, but it used to be. We talked about this earlier when we talked about inhaled drugs, so there it is. Here you can see the Advair discus, which is open now. So here you have the lever. So you push the lever backwards to cock it. That will reset the timer, or the counter, and then you put it up to your mouth and take one breath. Here you can see the inside of the Foradil chamber. So you put the tablet right here, and then there's little sharp blades right here that when you press the button pierce the edges of this capsule. Then you put it up to your mouth and breathe it in. Next, we're going to talk about anticholinergics. Anticholinergics block the muscarinic receptors in the bronchi, and it's not approved for asthma, but it is sometimes used for asthma. The main use for it is in COPD. It's going to reduce bronchospasm and the amount of mucus that's present. There's very few systemic side effects with the inhaled version of this drug. There is a longer-acting anticholinergic out on the market nowadays, which is called tiotropium. Ipratropium or Atrovent, it takes about 30 minutes before it comes on, and it lasts about 6 hours. It's available as both an inhaler and a nebulizer. It's also available in combination with albuterol, and then it's called Combivent. And there's actually a nasal version that's available for allergic rhinitis. And then, like we said, tiotropium is newer and lasts longer, and it's available as a dry powdered inhaler. Methylxanthines, they are primarily central nervous system stimulants, but they also cause bronchodilation. They have some other actions. They cause cardiac stimulation, vasodilation, and diuresis, which can make them dangerous for patients who have heart conditions. In fact, the methylxanthines used to be used as antidysrhythmics for patients who had Brady dysrhythmias, but because they're relatively dangerous for the patients who have those, they're really not used that often anymore. These drugs are typically considered third line because of their high side effect profile and fairly narrow therapeutic range. The two drugs in this class are theophylline and aminophylline. Do you think that you could recognize those somewhere? Because we're only going to learn theophylline, but aminophylline is almost identical. Typically, they're going to be used orally when it comes to asthma. They last longer. They're metabolized in the liver. They have a variable half-life, so you have to kind of check blood levels occasionally to figure it out. When they become toxic, patients will have nausea, vomiting, diarrhea, restlessness, dysrhythmias, and seizures. Sounds good, huh? It also interacts with caffeine and Tagamet, which is an over-the-counter anti-acid medication, and then fluoroquinolones, and then also other central nervous system drugs. So they do have quite a lot of side effects and interactions. We are now done talking about bronchodilators, and now we're moving into anti-inflammatories. You should remember glucocorticoids from earlier in the semester. So they're going to cause these effects. They decrease the release of inflammatory mediators. They decrease the infiltration and action of white blood cells. So fewer white blood cells go to the area of inflammation. They decrease airway edema. They decrease airway mucus production, and this is extremely, extremely important. They increase the number of beta-2 receptors, and they increase the sensitivity of beta-2 receptors. That's so important, I'm going to say it again. Patients who use albuterol on a regular basis, they become desensitized to albuterol. Their bronchial receptors start to produce less and less of the beta 2 receptors, and those beta 2 receptors become less sensitive. Patients who use albuterol on a regular basis are more likely to die sudden death because their albuterol doesn't work as well when they need it to. When you give a patient a glucocorticoid, it resets those receptors and makes them more sensitive again. Yeah, I think you should remember that. Now we can give the glucocorticoids either systemically or inhaled. Systemic are going to have stronger effects, but they're also going to be unaffected by lung restriction. Both of those things are awesome. However, you're going to have more side effects, and side effects all throughout the body. Especially bad with long-term therapy, which often we are using in chronic respiratory diseases. When it comes to the inhaled version, there's a localized action. It's going to act really only in the lung, maybe a little bit in the esophagus and stomach. And then there's going to be fewer side effects. Some absorption does occur, typically from what goes into the stomach. And the disease might prevent penetration of the drug. So if they have severe bronchoconstriction, it might prevent the drug from getting farther down to where it needs to act in the bronchi. The inhaled versions do have two particular side effects that are unique to the inhaled versions. The first one is oral candidiasis. So by suppressing inflammatory response and immune response in the mouth and throat, it can allow yeast to grow up as an opportunistic infection. Another one is dysphonia or hoarseness. So when you breathe in your steroid inhaler, a lot of it is going down into your stomach, and so forget that. Some of it is going into your stomach, and that will cause general adverse effects. But when you breathe it in, some of it is coating the larynx, and that can cause hoarseness, also known as dysphonia. If you have the patient gargle, and they also use a spacer so they absorb more of it, then typically these two adverse effects are going to be not as bad or completely avoided. General side effects are associated with systemic use of steroids, and then also to some degree with some of the inhaled steroids, particularly the ones that get absorbed through the stomach. So adrenal suppression is going to tell your adrenal glands, hey, we've got plenty of cortisol around, we don't need you to produce any. You can have bone loss because of calcium decalcification of bones. So to prevent that, you want to have the patients exercise, take enough vitamin D and calcium. It's going to slow the growth in children, but supposedly it's not going to affect their ultimate height. They're just going to be shorter, longer, but eventually they'll be the right height. And it can increase the risk of cataracts and glaucoma. It can cause peptic ulcer disease. It can cause elevated blood pressure, elevated sodium levels, elevated blood sugar, you name it, it causes it. And of course, let's not forget the lipodystrophies such as moon face, buffalo hump, and central adiposity. And decreased wound healing and protein catabolism. Here are some common corticosteroids. Fluticasone, also known as Advair Discus DPI, is available as either a combination with salmeterol, called Advair, or it's available by itself in an inhaler version. Flunisolide, called Aerobid, budesonide, called Pulmicort, beclomethasone, and triamcinolone. Almost all of these inhaled steroids also have allergic rhinitis preparations where you spray it up your nose and use them for allergic rhinitis. Just a quick little how does asthma work. So here is a normal bronchi or bronchus, and here is an asthmatic bronchus. So what you'll notice is that there has been bronchoconstriction, so it's narrower. There has also been inflammation and edema in the wall of the bronchus. So the bronchial wall is actually thicker than before. And then all of those things make the lumen smaller. than it is over here. And then on top of that, you're going to fill up that bronchus with mucus. All of those things are going to cause decreased airflow through the bronchus. And that is the mechanism for asthma and chronic bronchitis. Okay, next we're going to talk about a class of drug called mast cell stabilizers. Mast cell stabilizers are pretty crappy drugs. They don't really work very well. They're used for prophylaxis, but not acute treatment of asthma attacks. So they can be used for patients who have asthma that is associated with seasonal allergy, and they can also be associated for exercise-induced asthma. So you would take the drug before you exercise. And then they can also be used intranasally for allergic rhinitis. Again, they don't work that well. They're available over the counter if you can find them. And the way that they work is they prevent mast cells from degranulating, which is going to prevent the release of histamine and other inflammatory mediators. Next, we're going to talk about leukotriene modifiers. There are two potential approaches to making leukotriene modifier drugs. One is we can inhibit leukotriene synthesis. The second is we can inhibit leukotriene receptors. Of the three drugs, montelukast or Singulair is the best in terms of it works the best and has the fewer drug interactions, so that's the one that we're going to learn. In addition to being used for asthma, it can also be used for allergic rhinitis because the two diseases are very similar, just active in different parts of the respiratory tract. Leukotrienes are an arachidonic acid breakdown product. So if you remember when we talked about inflammation for test 3, we talked about arachidonic acid in the presence of an enzyme called cyclooxygenase, or COX-1 and COX-2, breaks down into prostaglandins, which in turn are inflammatory mediators. Well, if you take that same arachidonic acid and put it into the presence of lipoxidase enzymes, what you're going to get is leukotrienes. Leukotrienes increase the amount of inflammation, particularly in the respiratory tract. So by inhibiting leukotriene, either their synthesis or the receptors, what you're going to do is you're going to reduce, hopefully, the amount of respiratory inflammation. Now, as it turns out, because leukotrienes are just one of like 15, 18 different inflammatory modifiers, they don't really work that well. Okay, now that we've talked about all of the different drugs, let's talk a little bit about approaches to asthma treatment. Asthma is typically broken into stages or categories. We call them mild intermittent, mild persistent, moderate persistent, and then severe persistent. And typically with mild intermittent, the only thing that you would do is give them an inhaler. Nowadays, the thinking is that even patients who are in mild intermittent, because they have underlying inflammation, the right thing to do is give them an anti-inflammatory of some kind, whether they feel like they need it or not, because that will help prevent the underlying damage from occurring. The key is, if a patient is anything above mild intermittent, no matter what drugs they're on, they're undertreated. So if a patient is mild persistent, they're undertreated. We need to increase the dose of something or add a new drug so that we can get them back down to mild intermittent. One of the other things is that in the old days, they used what was called a step-up approach. So the patient has some symptoms, you give them a little bit of drug. If it doesn't get better, you add a little bit more drug, and you keep adding and you keep stepping up until it's under control. Now, because you're talking about the respiratory tract and we're talking about breathing and life itself, that might not be the best approach. So now, what's much more common is what's called the step-down approach. So when a patient has asthma symptoms, you hit them and you hit them hard with a lot of drug and a lot of variety of drug. Once the patient is under control, you lower the dose and reduce the number of drugs and lower the dose until the patient is controlled but has just a little bit more symptoms, then you step them back up one step. So the idea is you get control of the symptoms, good control, and then you reduce the dose until the patient starts to have increased symptoms again, and then go back up one level. And that's known as the step-down approach. When it comes to COPD, it's very similar to asthma in a lot of ways. Chronic bronchitis is much more treatable than emphysema is, and the main drug that we're going to use for COPD is going to be ipratropium. By reducing mucus and bronchospasm, it reduces the two major problems that a patient has in COPD, particularly chronic bronchitis. It doesn't necessarily do anything for the actual underlying disease, which is inflammatory in nature. So again, the current thinking is that a patient who has COPD, no matter how advanced or low it is, needs to be on some kind of anti-inflammatory. In a very advanced disease, the patients can get low levels of oxygen. The reason it's low is because if you turn the oxygen level up too high, you'll reduce their primary drive to breathe, and the patient will go to sleep, stop breathing, go to sleep, and never wake up. Okay, we're going to briefly talk about some allergic rhinitis medications: antihistamines, intranasal glucocorticoids, intranasal cromolyn, montelukast or Singulair, and then some pathomimetics or decongestants. On this particular slide, all I'm going to say is that cromolyn doesn't really work very well. Montelukast, some patients say it works. Most patients say, it didn't really help that much. Your mileage may vary. For some people, it does really work well, though, so it's worth a try if nothing else is working that well. Decongestants work by stimulating alpha-1 receptors in the nose, which in turn is going to cause vasoconstriction and reduce the amount of swelling in the nose. The two major drugs that are over the counter are pseudoephedrine and phenylephrine. Oxymetazoline is a nose spray only and works for 12 hours. It is a little bit stronger than either of the other two. Pseudoephedrine is the subject of much debate because it can be used to make crystal meth. So naturally, every single one of you out there are potential meth cooks. You've all seen Breaking Bad. You know how easy it is. You can make the blue stuff. And so, as a result, the FDA and the EPA and the DEA and the ATF have all conspired together to make it so that you can't get as much pseudoephedrine. So it's no longer available directly over the counter. Now it literally is over the counter. So you actually have to ask the pharmacist for it. You have to provide your driver's license, and then you can only get a certain amount each month. You can get no more than one package per day, and there's a limit on the amount of drug that's available in each package. So the bottom line is, if you need decongestants on a regular basis because of allergic rhinitis, you either need to get a prescription, which incurs more costs because now you have to go see your doctor, or you need to stock up when it's in the off season so that you'll have some extra for later. Phenylephrine doesn't work as well, it doesn't work as long, but it does have fewer side effects, supposedly. When it comes to antihistamines, we break them up into two main generations: first generation, second generation. The first generation have more side effects, in particular anticholinergic side effects and drowsiness. So you're often going to get as side effects drowsiness, dry mouth, dry eyes, and confusion. If you've ever taken Benadryl, maybe you've experienced those things. The three major ones you need to know there are diphenhydramine, which is Benadryl, chlorpheniramine or chlortrimeton, and then hydroxyzine. As an honorable mention, I'll mention doxylamine, which is the antihistamine that's in NyQuil. It's also available over the counter as a sleep aid and supposedly has fewer side effects than Benadryl in terms of the grogginess. First generation antihistamines are highly desired for colds because in a cold there's actually very little histamine being produced. So most of the way that they're therapeutic in a cold is by those drying side effects. The anticholinergic side effects is actually what you want in a cold. The second generation drugs, on the other hand, Allegra, Claritin, Clarinex, and Zyrtec, those particular drugs, and now we have Xyzal, which is a levocetirizine. It's the left hand of cetirizine. So those drugs have fewer side effects, so they cause less drowsiness. So you typically are going to want those when you have something like seasonal allergies where you don't want to be tired. So for a cold, first generation. For allergies, second generation. Antihistamines don't necessarily work that well for all patients, and again, you're only targeting one anti-inflammatory or one inflammatory mediator out of 18 or 20 different ones. So it will help some people a lot, and it'll help a lot of people a little, but there's a lot of people that it doesn't help very much. Next, we have cough suppressants. There are three major types of cough suppressants. The first one are opioids, and the two opioids in particular that are typically prescribed as cough suppressants are codeine and hydrocodone. They reduce the cough reflex centrally in the brain. They reduce the brain's response to cough stimuli. All of the adverse effects that go along with opioids go along with these particular drugs. The same precautions go, the same assessments go. So you might want to review what those assessments are, especially if you got it wrong on a test. When it comes to the other two, they're non-opioid. We have dextromethorphan, which is a codeine derivative. It's similar to codeine, but it doesn't cause euphoria and all the other things that codeine causes. Now, it will make you a little bit drowsy if you drink too much of it. So naturally, we have some kids who get as much as they can and drink too much of it, and they get, drowsy. Now, because of that, there's talk about making dextromethorphan a controlled substance. I just don't see a particular need in that, but, what do I know about freedom? An important thing about dextromethorphan is that it does inhibit cytochrome P450 and goes through the 2D6 pathway. You don't need to know that for your test, but it might be helpful later on in life, especially if you want to become a nurse practitioner. The last one is called benzonatate, also known as Tessalon pearls. The reason they are called pearls is because they look kind of like little yellow translucent pearls. They are a local anesthetic. Now you swallow these, so they work in the stomach. Weird. You have cough receptors in your stomach. Huh, who knew? Anyway, don't chew them. And the very last respiratory drug is expectorants. There's only one that's really effective, and that's guaifenesin. You need higher doses than usually present in over-the-counter in order to work. And what you see is that over-the-counter is like 1 to 200 milligrams every 12 hours, whereas the prescription dose is 600 to 1200 milligrams. Nowadays, with Mucinex DM extra strength and 12-hour and all that stuff, you can actually get the prescription strength over-the-counter. Yay! In order to work, you have to be hydrated, so patients need to drink water along with the guaifenesin. There are quite a few people who think that the guaifenesin really isn't doing anything, and it's actually just the water thinning out the mucus, making it easier to cough up. I'll let you be the judge. Next, we have mucolytics, which actually thin mucus, and they can both cause bronchospasm, so they're not used very often. You can also use normal saline, which basically just hydrates the lung, hydrates the mucus, helps it to cough up easier. Just a note that one of the potential side effects of using first generation antihistamines on patients who have bronchitis is that it can potentially dry up the mucus in the lung, making it too hard to get out.